Good morning, respected teachers and my co-PGs. Today I am here to present a seminar on salivary gland disorders. These are my contents: the classification, salivary gland tumors, conclusion and references. Introduction. Saliva is produced by three major paired salivary glands and numerous salivary glands distributed throughout the mouth and extending into the tracheobronchial tree. The daily secretion of saliva is almost 1.5 liters per day, with the submandibular glands having the highest secretion, almost 70%, parotid glands 25% and sublingual gland 5%. It is slightly acidic and has a pH ranging from 6.7 to 7.4. There are various classifications of the salivary gland according to the features. First is exocrine glands, mesocrine glands, serous salivary glands secreting the thin serous liquid, mucous salivary gland which secretes more amount of thick mucus, seromucous salivary gland which secretes both the serous and the mucus secretions, major salivary glands and minor salivary glands. Now, what is the composition of saliva? It consists of 99.5% of water and 0.5% of solid, which includes various cellular constituents, various inorganic ions, major and minor ions, and various secretory proteins and glycoproteins. Among the cellular constituents, there are various yeast cells, bacteria, protozoa, polymorphonuclear leukocytes and desquamated epithelial cells. Various major and minor ions, inorganic ions, sodium, potassium, chloride, bicarbonate, magnesium and calcium, and various secretory proteins and glycoproteins which include albumin, blood clotting factors, B2 microglobulin and immunoglobulins. Now, what are the functions of saliva? The functions of saliva is digestive function. It contains various enzymes like amylase, lipase and all the digestive enzymes which aids or improve in the digestive function. Various lubricating functions, like because it keeps the mouth moist and it lubricates the various the tongue and the mucosa and the oral mucosa, thus lubricates the oral cavity. It protects the teeth because saliva contains various antibacterial proteins, and this helps to prevent the dental caries, thus protects the teeth. Protection from injuries, it dilutes all the various toxins present, so thus it protects from injuries. It maintains the oral mucous membrane. It has various antibacterial properties like lactoferrin because of the presence of lactoferrin and lysozyme. It helps in debridement and lavage. It excretes out all the toxins and flushes out all the toxins and microorganisms, that thus helps in debridement and lavage. It has various anti-carcinogenic activities because of presence of various immunoglobulins. It helps to repair the soft tissue and it maintains the tooth integrity. So, these were all the functions of the saliva. Now, the major salivary gland that can be classified into various forms. The secretions can be classified into various forms: serous, mucous and mixed. The major salivary present all over the among the various major glands, the parotid gland, it is the largest of all the glands, which is wedge in shape and is located in front of the ears on each side. Parotid saliva is secreted from a duct which is known as the Stenson duct, which opens this orifice in the vicinity of the maxillary first and the second molar. The submandibular gland, it is a round biconvex salivary gland situated in the anterior part of the digastric triangle, and its duct is known as the Watston's duct, which is thinner than the parotid gland. The third is a sublingual gland, which it lies above the mylohyoid and below the mucosa of the floor of the mouth, and its duct is known as the Bartholin's duct. Now, the main thing, the classification of salivary gland disorders, it is classified into various according to its various categories. First is the developmental disorders, functional disorders, obstructive disorders, asymptomatic enlargement, autoimmune disorders, infection, cyst. First come to developmental disorders. The first one is aberrancy. It is defined as a situation in which the salivary gland tissue develops at a site where it is not normally found. It is also known as an ectopic salivary gland. It occurs anywhere other than the normal area between the territory of the first and the second branchial arch, in the lateral neck, in the pharynx, or in the middle ear. Its clinical features is it can be present in any cervical region, near the parotid gland, body of the mandible, developmental lingual salivary gland depression, salivary tissue in the neck, gingival salivary gland choriostoma. Choriostoma is a tumor that arises from the various germ cell layers. Now, its clinical significance is that it may develop a retention cyst or a neoplasm. The second thing is aplasia or hypoplasia. It is a congenital absence of the salivary gland. It may occur in association with any developmental abnormalities such as atresia of the lacrimal puncta or the congenital malformation of temporomandibular components. Its causes are usually congenital origin, so therefore it causes because of the ectodermal origin. Clinical features, symptoms is xerostomia is seen. Significance causes various rampant dental caries and early loss of tooth. Appearance of the oral mucosa seems to be dry. It is sometimes pebbly, shows tendency for accumulation of debris because it doesn't flushes out. Signs shows crackling of lips, fissures in the corner of the mouth. We can easily see through CT scan whether unilateral gland is missing. The diagnosis is decreased production of saliva without any clinical anomalies, and the management is we can manage it by the maintenance of oral hygiene. The third thing that is a developmental disorder is the hyperplasia of the salivary gland. Here there is an increase in the size of the number of cells of the salivary gland, thus increase in the size, and there are various causes for this. First is the hormonal disorders, which includes the endocrine disorders or the menopause, metabolic disorders, which includes the gout or the diabetes mellitus, which is the increase in the number of increase in the amount of uric acid and deposition in the short bones is gout. Autoimmune reasons are the Sjogren's syndrome and Waldenstrom macroglobulinemia. Waldenstrom macroglobulinemia, it is cancer in the white blood cells, which is replaced by various abnormal amount of white blood cells. Also various syndromes are associated with it, like the aglossia adactylia syndrome, which is characterized by the loss of tongue because the absence of tongue and the absence of limbs or the fingers. Heerfault syndrome, also it is a type of sarcoidosis seen. Felty syndrome is also a triad which includes splenomegaly, and it includes rheumatoid arthritis and various other causes of hyperplasia, which includes the hepatic disease, starvation, alcoholism, inflammation, benign lymphoepithelial lesion, adiposity, hypothermia, oligomenorrhea, or the irregular menses, and various certain drugs. What are the clinical features of hyperplasia? It is more common in minor salivary glands as compared to major, and usually seen in the palate. Its size is it appears as a small localized swelling of varying size, which measures from several millimeters to 1 cm, usually on the hard palate and the junction of the hard and the soft palate. Surface, when we touch it, it is firm, it is sessile, and it is normal in color. It is usually asymptomatic. Radiographical features will diagnose this condition. The increase in the size of the gland seen in the left side here in the image. Management is we can excise for microscopic examination. The fourth developmental disorder is the developmental salivary gland defect, which is also known as the Stepney's cyst or defect or static bone cavity or cyst. It is a developmental inclusion of the granular tissue within or more commonly adjacent to the lingual surface of the body of the mandible. The image is shown here, the arrow is shown here, and this is a cavity or a cyst that is formed where the salivary gland is usually present. Clinical features, it is more common in males and it is located in the posterior body of the mandible in the sublingual gland bony defect. It is usually asymptomatic and only diagnosed in radiographic examination. We can either feel a notch or a depression in the posterior area, posterior aspect of the mandible. Radiographic features, it is present usually below the mandibular canal and just above the inferior border of the mandible, anterior to the angle of the jaw, just posterior to the third or the second molar. Its size is round or ovoid, and it varies from size to 1 to 3 cm. Borders is well defined dense radio-opaque border, and it is only diagnosed radiographically. Differential diagnosis can be with radicular cyst, but if it is associated with carrier's teeth, and residual cyst if there is any extraction, pre-extraction radiograph or any history of pre-extraction, evidence of deep caries. Management is there is no treatment required. That was all about the developmental disorders. Now come to functional disorders, and the first thing that we see is siluria or tylism, and it is an increased amount of saliva or an increased salivary secretion. The mechanism is the secretory innervations of the salivary glands are primarily under the control of the parasympathetic nervous system, and stimulation of this parasympathetic nervous system causes profuse secretion of the watery saliva. Now, the various etiology behind this is various drugs which stimulate the salivary flow, which are known as silogogues, lithium, cholinergic agonist, various local factors like stomatitis, anug, erythema multiforme, various systemic diseases like paralysis, alcoholic neuritis, Parkinson's disease, epilepsy, Down syndrome, and undetermined neuromuscular disorders, or any head injury or any stroke, any history. There can be any miscellaneous causes like psychic factor, metal poisoning, and facial paralysis. The clinical features is drooling of saliva in either side of the face, various emotional and physical impairment, various cheek scaring, lip chapping, infection from constant exposure to saliva. Management is oral motor training, removal of the local factors. We can prescribe atropine. Various other drugs, scopolamine 0.4 to 0.6 milligram, methylene 50 to 100 milligram, and propathelin 15 to 30 milligram. Surgery, we can relocate the duct, and we can also perform bilateral tympanic neurectomy, where we can cut the nerve partially or completely. The second functional disorder is xerostomia. It is a subjective clinical condition of less than normal amount of the saliva. It is a clinical manifestation of salivary gland dysfunction. There are various causes related to xerostomia. It can be radiation induced. It can be various systemic alterations like in conditions like diabetes. It can be because of various drugs, pharmacologically induced xerostomia, drugs like antihypertensives, antihistamines, anticonvulsants, various developmental disorders, or various local factors. The clinical feature shows effect of xerostomia on the oral functions, dryness of the lips, dryness of the mouth, the palate, and the sticking of the tongue to the palate because of loss of moisture. Salivary gland enlargement is seen, and effect of xerostomia on various normal functioning like speech or swallowing. Various clinical signs of xerostomia is also seen, dryness of the pharynx, larynx, and repeated thrust seen while drinking, repeated thrust is seen while having food, especially in between meals. Candidiasis can be seen, residual saliva is also seen. How can we manage this? We can stimulate the salivary production. By local stimulation, we can chew some sour candy or various chewing gums or paraffin wafers, and by systemic stimulation, because of artificial saliva or any salivary substitute, we can use artificial saliva, carboxymethyl cellulose, sorbitol, and all this. Oral hygiene product, we can use we can avoid, we can use sour products, or we can have sour candies. We can discontinue the drug that give rise to this condition, xerostomia. So this was the management of xerostomia. This is tabulation showing the composition of the artificial saliva, which is usually preferred in such patients. This is a salivary substitute. Now comes to the obstructive disorders. Obstructive disorders, the first one is sialolithiasis. It is also known as salivary gland stone or salivary gland calculus. It is the formation of the calcific concretions within the parenchyma or ductal system of the major or the minor salivary glands, and these are the most common calcifications found in the soft tissue of oroorbital region. It has two types, is ductal or granular. Its prevalence is 83% in the submandibular gland, 10% in the parotid gland, and 7% in the sublingual gland. 83% is seen in the submandibular glands because of the tortuous duct, because the orifice is much smaller than the duct, and because there is a mucus, more amount of mucus and calcium and phosphates present in the secretions of the submandibular gland. There is various reasons for this to occur in the submandibular gland. There is a tortuous duct in the submandibular gland. Now, what is the clinical features of this? Mostly in the middle-aged patients with slight male predilection. The symptoms is pain that can be moderate to severe under pressure, swelling, intermittent transient swelling in between the meals or which resolves after meals. Systemic symptoms that is seen, fever and malaise. Signs is inflammation, pus on palpation near the duct, ulceration and sometimes absence of duct. Pus. The radiographic features are cyalography can be indicated when cyaloliths are radiolucent. Usually the cyaloliths in acute cyaloliths are usually radiolucent, which eventually becomes radio opaque. Sight, white or grey radiopacity in the region of glandular apparatus may be solitary or multiple, can also be seen in the ductal area. Shape is oval or cylindrical with multiple layers of calcification. Borders is smooth with even radio density. Size which varies from up to 5 mm. CT is dense radio opaque area. In contrast study we can find out. Sonography shows calculi. The differential diagnosis is gas bubble. In case of gas bubble, it comes out very quickly and it is more round as compared to the calculi seen. Hyoid bone, how can we distinguish hyoid bone? Hyoid bone can be distinguished bilaterally when we take panoramic radiographs. We can distinguish hyoid bone. In case of myositis ossificans, we can distinguish if there is a pain in the mandibular region, we can easily distinguish myositis ossificans. Phleboliths also we can distinguish very easily. Calcific submandibular lymph nodes, there is a painful enlargement in the lymph nodes and thus we can distinguish. Chondrodystrophia calcific congenita, it is usually seen in the early stages. How can we manage this? By manual manipulation we can see. Whenever there is a stone in the submandibular duct, we can either remove it. Stone in the submandibular gland also can be removed. We can also prescribe antibiotics. We can do salivary gland endoscopy, and we can locate the cyalolith present, and we can do lithotripsy. Lithotripsy is breaking the cyalolith into various pieces and then efficiently taking out from the duct. Various other things that does this obstructive disorders is mucus plugs. Any mucus plugs which doesn't allow the saliva to pass out through freely through the duct can cause obstructive disorders. Various strictures or stenosis within the duct. Various foreign bodies, sometimes the fish bone or sometimes the small the wheat sticks can cause the foreign body obstruction. Various extraductal causes and various parotid fistula which arises from usually from the parotid gland. This all causes the obstructive disorders. Now come to different category, that is cyst of the salivary glands. The first is the mucocele, which is also known as mucus extravasation cyst. It is swelling caused by pooling of saliva at the site of the injured minor salivary gland, and it is not a true cyst as it lacks an epithelial lining. The etiopathogenesis behind this, it can be trauma that is caused by the laceration of a minor salivary gland duct, resulting in extravasation of the mucus into the connective tissue, or there can be an accumulation of the mucus in the connective tissue, and with the continuous pooling of saliva, a clear demarcated cavity develops which has no epithelial lining. Therefore, it is not a true cyst. The clinical features are, it usually is seen in the younger patients of both the sexes, and the site is the inner, most common site is the inner aspect of the lower lip, palate, cheek, tongue and floor of the mouth, usually painless. Size varies from 1 to 2 mm and maximum 10 mm. Appearance is a bluish marks which is usually oval or dome shaped. Consistency is soft, sometimes hard but usually soft. Aspiration is sticky, viscous, clear fluid, and recurrence rate is very high. The diagnosis is laboratory diagnosis is we can do by the vacuolated macrophage, which is seen by mucifage, and by clinical diagnosis there will be a dome shaped swelling and usually on the lower aspect of the lower lip, the inner aspect of the lower lip. Differential diagnosis is vascular lesion and superficial non-keratin cyst. We can differentiate this by the aspiration and early mucoepidermoid tumor and adenocarcinoma with the help of metastasis, or with the help of metastasis. So, by this way we can differentiate those. The management is surgical excision. We can either completely surgical excise it, or we can do it by a cryo probe through cryosurgery. Now, the second cyst is ranula, which is derived from a Latin word rana tigrina, that is frog belly. The term ranula is used for the mucosals occurring in the floor of the mouth in association with ducts of the submandibular or sublingual glands. It has various types: superficial, plunging or cervical. The clinical features are: the site is usually on the floor of the mouth, below the tongue and on the side of the frenum, usually unilateral. Symptoms are: it develops as a slowly enlarging painless mass on one side of the floor of the mouth. When the swelling suddenly grows, it may be painful. Big granula may cause difficulty in speech or eating or deglutination. Appearance: it is a blue domed shaped swelling like a frog's belly. The shape is spherical or dome shaped, which is visible superficially half. Size: early morning it is smaller, but it is largest just before meals because of the increased secretory activity in periods of gustatory stimulation and water absorption from the pooled mucus during inactive period. Consistency is soft and fluctuant. Aspiration gives out sticky clear fluid. Radiological features shows homogeneous water density mass with clear boundary, and MRI shows low signal intensity of T1 weighted images, very high signal intensity on T2 weighted images. How can we differentiate it? Sublingual dermoid, it is usually midline and not translucent, but ranula is translucent. Submandibular lymph nodes, hard and firm in consistency. Management can be through surgical excision or partial excision with marsupialization, which is management of cyst. The third thing that is cyst is salivary duct cyst, which is also known as mucus retensus cyst, mucus duct cyst or cyalocyst. The etiopathogenesis behind this, it is caused by the obstruction of the minor salivary gland duct, which causes the backup of saliva. This continuous pressure dilates the duct and forms a cyst-like lesion. The clinical features are: it occurs in older patients with no sex predilection. Site is most commonly in the parotid gland, intraorally, common on the floor of the mouth, buccal mucosa and lips. Appearance is it is like mucosals. It is soft and fluctuant, which appears bluish. And multiple retention cyst. In some cases, patient may develop various multiple painful nodules, which are demonstrated as dilated ductal orifice on the mucosal surfaces. Now, how can we manage that? We can do a surgical excision. We can prescribe antibiotics like erythromycin, chlorhexidine mouthwash, or we can also give various silologs. Various silologs are listed here: pilocarpine, bromhexin, neostigmin, various vitamins, malic acid, nicotinic acid, potassium iodide, cevimelin, bethanecol. Viral infection, mumps. The first viral infection is mumps. It is also known as epidemic parotitis. It is an acute contagious viral infection characterized chiefly by unilateral or bilateral swelling of the salivary gland. It mainly affects the major salivary gland but also affects the testis, meninges, pancreas, heart and mammary gland. It is caused by paramyxovirus. Its transmission is through saliva and urine. Clinical features is it is common in boys. Between the age group of 5 to 15 years. Incubation period is 2 to 3 weeks. Site is parotid gland, usually bilateral. Prodromal symptoms are headache, chills, moderate fever, vomiting, pain below which last for almost 1 week. Symptoms are pain produces upon mastication, especially while eating sour food. The various typical sign of this is enlargement of the parotid gland, which elevates the ear lobule, and the sublingual gland involvement is there, sometimes bilaterally. Complications is orchitis. Orchitis, inflammation of the testis is seen, which is a major complication of this thing. Pancreatitis, because of the increased level of serum lipase, pancreatitis is seen. Meningitis or endocarditis is also seen. It is a big complication. Other complications are deafness, mastoiditis, meningoencephalitis. All these complications are seen in mums. How can we manage that? By giving live attenuated vaccines, which is given to the baby or the infant within 12 to 15 months of life, and it is again repeated up to 4 to 5 years of age. There is no control of pain and swelling. We can prescribe non-aspirin analgesics and antipyretic, rest and diet restriction. We can avoid sour food and drinks, carbonated drinks. The second viral infection is cytomegalovirus inclusion disease, which is also known as a salivary gland virus disease, and it is caused by a herpes virus, which is known as cytomegalovirus, as the name suggests. It is very common in immunocompromised, immunosuppressed patients. Congenitally, it starts congenitally, sometimes primarily in infants and children, sometimes adults. In newborns, it causes generalized, and it can be fatal, which involves the liver, lungs and the central nervous system. In infects, it is permanent CNS involvement. Mental retardation is seen, seizures and hepatosplenomegaly. Hemolytic anemia and hemorrhagic tendency is seen. Now, bacterial infection. The acute bacterial sialadenitis and the chronic bacterial sialadenitis. Acute bacterial sialadenitis is also known as acute suppurative parotitis, which is caused because of various microorganisms, Staphylococcus aureus and Streptococcus usually. Predisposing factors: dehydration, malnutrition and cancer. Various surgical procedures, after various surgical procedures, poor oral hygiene and various drugs like diuretics and antihistamine. Clinical features: it is common in adults. It is unilateral parotid gland involvement, fever, pain in the angle of the jaw, leukocytosis is seen, gland is enlarged and tender with elevated ear lobule, and lymph nodes are palpable. Radiographic features shows sonography showing swelling and increased vascularity. It can be managed by proper oral hygiene, soft diet, antibiotics, electrolyte balance, stimulation of saliva and surgical drainage. Now, the chronic bacterial sialadenitis, it is caused because of the ductal obstruction, other various congenital causes like congenital stenosis or stricture of the duct, Sjogren syndrome or any previous viral infection history. It is usually seen in the age group of 3 to 5 years with minimal pain, unilaterally swelling in the angle of the jaw. Salivary flow is accompanied by flecks of purulent material when we palpate near the duct. In sialograms, we see multiple ectasias and dilation of the main excretory duct, and it can be managed by radiation therapy, surgical removal, antibiotics injection, ligation of the stensions duct. So, this was all about the bacterial infection in the salivary glands. Now, come to the autoimmune disorders. The first one is the Sjogren syndromes. It is a chronic inflammatory disease that predominantly affects salivary, lacrimal and other exocrine glands. It is predominantly affects the middle-aged and elderly women. It is categorized into two parts, the primary Sjogren syndrome and the secondary Sjogren syndrome. The primary Sjogren syndrome is also known as Zika syndrome, and it consists of dry mouth and dry eyes, xerophthalmia and xerostomia. And the secondary Sjogren syndrome, it consists of dry mouth, dry eyes as well as an additional collagen disorder, usually the rheumatoid arthritis or systemic lupus erythematosus. It is an immune disorder in which the own body's own immune system attacks its own immune system. Systemic lupus erythematosus. The clinical features is, it is seen in middle-aged adults and females. We can see the dryness in the eye, which is also known as keratoconjunctivitis, Zika, and various connective tissue disorders. Dryness of other organs is seen, like pharynx, larynx, nose and vagina. The oral manifestation is xerostomia, pus emitted from duct on palpation, unilateral or bilateral enlargement, pooling of the saliva in the floor of the mouth, mucosa is glazed, dry and tends to form wrinkles. Periodontal diseases occurs, severe dental caries seen, regional swollen lymph nodes seen. Radiological features. Sialography. The most typical finding is sialactasia, which produces a snowstorm appearance as a result of leakage of contrast medium, atrophy of ductal tree seen, or a cherry blossom or fruit laden branchless tree appearance of the obstructed ductal system is seen. Salivary CT scanning, which is done with the help of technetium pertetrate, may be useful in demonstrating impaired salivary function. Here on the left side, we can see the image showing salivary CT scanning, and we can see there is impaired salivary function because of aplasia. Laboratory findings or laboratory diagnosis can be done through various ways, like Rose-Bengal staining test. Rose-Bengal staining test, it is done in keratoconjunctivitis Zika, where this dye stains pink in color, and thus we can prove. The second thing is skimmer test. Skimmer test is done to see the ocular dryness. Here we can keep a filter paper in between the eye and the eyelids and keep it for 5 minutes. If it absorbs less than 5 mm in 5 minutes, then we can suspect that there is an ocular dryness. Sialometry is also, it also diagnoses the ocular or the salivary content. Sialochemistry, we can check the various immunoglobulins or various enzymes. Immunologics also, we can check through various immunoglobulins. Hematological investigation, here we can see a very raised ESR, and thus we can investigate. Also here the leukopenia is seen in hematological investigation. Microbiological investigation, presence of various microorganisms is seen, and also we can do salivary gland biopsy. The management can be ocular lubricant, methyl cellulose, oral hygiene maintenance, salivary stimulant like bromhexin, pilocarpine, and or surgery. The second autoimmune disorder is the Mikulit's disease or the benign lymphoepithelial lesion. It was first described by Mikulicz in 1888 as a symmetric or a bilateral chronic painless enlargement of lacrimal or salivary glands. Here we can see enlargement of the lacrimal or the salivary gland. The image shows here the enlargement of the lacrimal glands, which exhibits both inflammatory and neoplastic characteristics. Its disease was confused with various other diseases such as leukemia or tuberculosis, and in that case it was known as Mikulitz syndrome. It has a clinical features of female predilection more. It is in middle age. Unilateral or bilateral enlargement is seen. Occasional pain and xerostomia is seen. Duration may be from few months to various several years. Clinically, we can diagnose by unilateral or bilateral enlargement of the parotid and lacrimal gland. Laboratory diagnosis we can do by biopsy, where we can find solid nest or clumps of poorly defined epithelial, which is termed as epimyoepithelial islands. Also, we can manage by surgical excision of the glands. Now, this was all about the salivary gland disorders. Now come to the salivary gland tumors. These are my contents. The introduction. There are nearly 40 different entities of major and minor salivary gland tumors, ranging from benign to extremely malignant. Approximately 80% of the parotid gland tumors and approximately half of the submandibular gland and minor salivary gland tumors are benign. In contrast, more than 60% of the tumors in the salivary gland are malignant. Now, this was the WHO classification of the salivary gland tumors that was given in 1999. The various classification of adenomas and carcinomas are listed here. And adenomas, pleomorphic adenomas, myoepithelioma, basal cell adenoma, Warthin's tumor, oncocytoma, canalicular adenoma, sebaceous adenoma, ductal papilloma, which includes the inverted intraductal and shallow-adenoma, cyst adenoma, which includes the papillary and mucinous cyst adenoma. Carcinomas, acinic cell carcinoma, mucoepidermoid carcinoma, adenoid cystic carcinoma, polymorphous low-grade adenocarcinoma, epithelial myoepithelial carcinoma, basal cell adenocarcinoma, sebaceous carcinoma, papillary cystoadenocarcinoma, mucinous adenocarcinoma. Oncocytic carcinoma, salivary gland carcinoma, adenocarcinoma, malignant myoepithelioma, carcinoma in pleomorphic adenoma, squamous cell carcinomas, small cell carcinoma, undifferentiated carcinomas, and various other carcinomas. Other than adenomas and carcinoma, there are various non-epithelial tumors, malignant lymphomas, secondary tumors, unclassified tumors, and tumor-like lesions, which includes the sialadenosis, oncocytosis, necrotizing sialometaplasia. Now, I have discussed some common tumors here. The benign tumor, which includes the pleomorphic adenoma, which is also known as iceberg tumor or endothelioma or branchioma or enchondroma. This term is suggested by Willis, which is characterized by the unusual histological pattern of the lesion. These tumors, when viewed histopathologically, it gives a mixed appearance of different types of cell. Pleomorphic means mixed appearances of different types of cells is seen. Various types of cells. Myoepithelial cells are responsible for the morphologic diversity of tumor, which include production of the fibrous, mucinous, chondroid and osseous structures. Differentiation of ductal reservoir cells. Intercalated duct reserve cells can differentiate into ductal and myoepithelial cells, and later that can undergo mesenchymal metaplasia since they inherently have smooth muscle-like properties. Neoplastic altered epithelial cells. A neoplastically altered epithelial cell with potential for multidirectional differentiation may be responsible for pleomorphic adenoma. The clinical features of pleomorphic adenoma is the women predilection is more and usually arises in the 4th to 6th decade, and 90% is seen in the parotid gland and intraoral palatal gland on the lip. Symptoms: it is painless, it is small and quiescent nodule which slowly begins to increase in size, sometimes intermittently. The shape is usually round or oval initially, but it becomes lobulated as it grows, and in some cases intraorally swelling may be observed. Usually seen in the palate, and its surface is smooth. Sometimes it is bosselated and occasionally crossed by deep furrows. There is no fixation either to the deeper tissues or overlying skin. It is firm and rubbery in consistency, and sometimes cystic degeneration may be seen, mostly in the palatal. As I said, it is seen in the lateral aspect of the palate. Radiographically, when we may see erosion of the underlying bone in some cases. It can be diagnosed clinically by smooth surface enlargement of the parotid region. Scalography, when we see a ball in hand appearance. The arrows in the first image suggest there is a ball in the hand appearance. CT images show the extension of the location. We can easily rule out by the symmetry. Axial section of CT here shows the extent of the lesion and superficial erosion of the maxillary residual alveolar ridge in the molar region. The management can be surgical excision. Parotid gland can either we can remove the parotid gland, parotidectomy, or the submaxillary gland can be removed, and the tumor along with the tumor in continuity. Also intraoral lesion, extra capsular incision can be done. Hard palate can be excised with overlying mucosa. Lift, soft palate can be enucleated or extra capsular excision can be done. The recurrences rate is 5 to 30% due to hypercellularity, incomplete resection and encapsulation. The second type of tumor is the Warthin's tumor, which is also known as adenolymphoma or the primary cystadenoma lymphomatosum. It was first described by Albrecht and Archt, but is usually bears the name of Warthin in recognition of the pathologist who described it in USA in 1929. It contains different types of tissue, and various causes or various pathogenesis of these Warthin's tumor is because of the heterotrophic salivary gland tissue. Tumor arises from the salivary gland tissue entrapped with the paraparotid or intraparotid lymph nodes during the embryogenesis or during the process of embryogenesis. There can be delayed hypersensitivity. It is most likely a delayed hypersensitivity disease, the lymphocytes being an immune reaction to the salivary ducts which undergo oncocytic change. HSU has suggested that it is an exaggerated secretory immune response and hypersensitivity response or hyperimmune response. Other factors which can cause is smoking and viral causes like Epstein-Barr virus. The clinical features is there is a more male predilection, almost 5 times than female, and it is very common in the 6th decade. Site, it is exclusively in the parotid gland lower portion. The tumor is generally superficial, lying just beneath the parotid capsule or protruding through it. The symptoms is usually painless, slow growing tumor over the angle of the jaw. Involvement may be bilateral or may be multifocal. Clinically, the shape or size is almost 1 to 3 cm. It is spherical in shape. It is smooth and well circumscribed and can be movable. When palpated, it is duffy and compressible. It can be firm on palpation as clinically indistinguishable from any other benign lesions of the parotid gland. Radiographically, when we see this, we see a round or oval shaped mass with smooth, well delineated contour. It contains cystic parts which are seen on the CT, MRI images and sonograms. On sonography, we can see a very clearly delineated mass with multiple cystic areas, and in Doppler mode, relatively abundant vascularization is observed. The diagnosis is very difficult. Laboratory diagnosis, we can it is an adenoma exhibiting cyst formation with papillary projection into the cystic spaces and lymphoid matrix showing germinal centers. We can do a superficial parotidectomy in the superficial part of the parotid gland, and sometimes we can remove the tumor. Malignant tumor, mucoepidermoid carcinoma. The term mucoepidermoid tumor was introduced in 1945 by Stewart, Foote and Becker, and it accounts for almost 6 to 9% of the salivary gland tumors, and as the name suggests, the tumor is composed of both mucus secreting cells and the epidermoid type cells, which is also a mixed type of cell which consists of mucoepidermoid types of cells. There are 2 categories here: peripheral mucoepidermoid carcinoma. This contains benign and malignant based upon the clinical nature and histological feature of the lesion. The clinical feature is it is equally distributed among men and women, and it occurs mostly in the 3rd to 5th decade. Site 60% in the parotid gland and 30% in the minor salivary gland, and it is also a painless mass and it is slow growing. Pain and facial nerve palsy, lacrimation, trismus, nasal discharge, and blood-tinged saliva are the symptoms. Rapidly growing, and it tends to infiltrate the surrounding tissues and regional lymph nodes metastasis. Extraoral ulceration can also be seen in cases of high-grade malignancy. In cases of minor gland tumors, asymptomatic tumor which is blue and red in color can be seen. The diagnosis can be done. It is difficult. Radiologically we can see in CT scan and we can diagnose this. In laboratory diagnosis or biopsy we can see various mucoepidermoid cells, mucus secreting cells along with the epidermoid cells. Management is subtotal parotidectomy in early stage, and facial nerve should be preserved. Total removal in advanced stages. Radial nerve dissection according to the lymph nodes that are affected we can do in cases or indicated in the evidence of metastasis. Also we can give radiotherapy in some cases of intermediate type of mucoepidermoid carcinoma. The second category is the first one was peripheral, and this is the central or intraosseous mucoepidermoid carcinoma. Its origin is cause is entrapment of a retromolar mucus gland, may originate from the entrapment of the retromolar mucus glands within the mandible, which subsequently undergo neoplastic transformation. Embryonic remnants of the submaxillary gland developed from the retained embryonic remnants of the submaxillary gland within the mandible, and neoplastic transformation of the mucus secreting cells commonly found in the epithelial lining of the dentigerous cyst. Here the female's predilection is more. The most common site is the mandible in the premolar molar area and does not extend anteriorly beyond the premolar area. Therefore, it is peripheral. Symptoms is painless swelling, and there may be paresthesia of the inferior alveolar nerve. The sign is that swelling may cause facial asymmetry and tenderness is present, and the regional lymph nodes are enlarged. When seen radiographically, as I have already told, the most preferred site is the mandible in the premolar molar area above the mandibular canal, and it appears as a unilocular or a multilocular expansile mass. The margin is well defined, well corticated, and often crenated or undulating in nature. We see a soap bubble or a honeycomb appearance. Lesion may have a soap bubble or a honeycomb appearance. The diagnosis is clinically not specific, but radiologically we can see a soap bubble or a honeycomb appearance. Differential diagnosis can be done. Ameloblastoma, radiologically it is difficult to differentiate. Diagnosis can be confirmed by the histopathological investigation, where we see the mucoepidermoid as well as the mucus secreting cells as well as the epidermoid cells. Odontogenic myxoma we can diagnose if there is any history of any missing tooth. Central giant cell granuloma, this is a peripheral mucoepidermoid which doesn't crosses the midline, but central giant cell granuloma, it frequently crosses the midline. The management is surgical excision. It can be treated by surgical excision of the tumor. We can do radial neck dissection in cases of metastasis with the lymph nodes which are affected. We can also do radiotherapy to control metastasis. So this was the salivary gland tumors, the most common salivary gland tumors. These are my references.